Welcome to the American College of Obstetricians and Gynecologists Video History Project. Today we're very fortunate to have with us Dr. Roger Smith. Roger is one of the foremost medical educators in our specialty. Roger, thank you very much for coming to be with us today.
It's a true privilege, sir.
Let's learn a little bit about you. Tell me, where were you born? Where were you raised? Go to school?
I was born in Tucson, Arizona, but moved away from there when I was about 3 months old, and went to Norfolk, Virginia, but settled into Central Illinois, Champaign-Urbana, about age 5, and that really was home for me. That's where I grew up. Went to Purdue for undergraduate, and then Northwestern for med school internship and residency. And from there, I went back downstate to Champaign-Urbana to a big multi-specialty group practice there. And I was in that for almost 10 years before I entered the Carl Clinic, exactly. And it wasn't until I sort of serendipitously ended up in academics after about 9 and a fraction years. Went to the Medical College of Georgia.
Well, before we go on, how did you wind up in academics?
It came about very much unplanned and serendipitous. I had gotten involved in some research and some other things in practice and had been nominated for a national award, but it required letters of recommendation. And being in practice and not seeing myself as an academician, I didn't have an old boys network. And about the time that happened, I received a postcard acknowledging receipt of a letter of recommendation for a med student that I had given. The postcard came from Dr. Don Sherline at the Medical College of Georgia. Well, I had met him and done a couple of grand rounds for him when he was at Rush Press St. Luke's in Chicago. And I thought, I wonder if he would remember me. Picked up the phone to see if I could set up an appointment to talk to him, and all of a sudden I had him on the phone, and yes, he remembered me, and he would review things, and by the way, he was looking for Chief of General Gynecology. And I laughed at him. You can't be that desperate. And a couple of months went by, and I got to wondering if he was serious. So I called him back, and yeah, he was serious. And I said, well, why don't I at least do a grand rounds or something so you don't waste the airfare? And I went down and I saw the environment that was there, the intellectual sparks that were flying, people asking interesting questions, things like that. So I went back and I tried to decide, would there be something that I could bring to it? The experience of having been in practice, the practicalities that we really didn't do and still don't do a good job of educating our residents for. So I called him up, asked if he was really serious. And he said yes, so I went back and did a second interview and I interviewed them. I said, what would I do on Tuesdays? That kind of thing. Finally decided I wouldn't know if I didn't try. So it was not by some grand plan, not exactly a very mature method of approaching life planning, but it worked out amazingly.
And from there?
From there, I spent 15 years at the Medical College of Georgia as the Chief of General Gynecology. I had gotten to know Jim Youngblood, who was president of the American College at the time, and he was looking for a residency program director. He was both chair and program director, and of course the obligations of the ACOG president are extensive and travel and everything, so he wanted to find someone who could come in and be the program director and vice chair during his presidency and the immediate past president roles that he was doing. And so he talked me into going to the University of Missouri, Kansas City. And I was there for 12 years. That department underwent a number of changes after Dr. Youngblood's departure and ultimate death. And an opportunity came up to join the faculty at Indiana University. About a year before it happened, the then chair, who had been there about 2 years, maybe 3 years, and I sat down over burgers at the boards, and we compared notes of opportunities that were growing in his department and opportunities that were being missed in the University of Missouri, Kansas City, at least as far as I saw them. And we just commiserated in that, and almost a year to the day, the stars aligned, and all of a sudden, he had a resignation of a clerkship director, and he needed somebody to come in and be, to take over part of that and to provide some continuity. And within 90 days, I was there on the faculty as vice chair for education and chief of the division of general OBGYN, and Over the 5 years that I was there, I performed as clerkship director, sort of interim program director, as we groomed someone to become that, and wore a number of hats for the school. It was a very exciting time.
Let's go back to the Medical College of Georgia. I believe that's the first time that I met you.
Yes, I think
around
probably.
that time, and I think we were in, that was either at a APGO or a CREOG meeting we were all going to at that time.
Yeah.
At that time, I recall you were making presentations on new and innovative educational approaches to OBGYN education.
I was very fortunate. In the department was Dr. Gerald Holzman, who was very much involved in education. And and he got me involved in a lot of the educational things. And it was apparent that we needed to look at how we did education. Hearkening back to that idea that maybe what we'd learned in practice and how do we do a better job of educating, how do we teach concepts and not just specifics. It made sense that that was an area that we ought to be looking into and that we ought to be able to do a better job of. We were wasting amazing talent and skills and doing the same old thing, and when there were things that we could do better or that we could help our learners with. These are brilliant people coming up. They're going to be the future of medicine. We owe it to them to try and use good tools and develop things. And so he and I had figured out ways that we could track resident experience by having a computer-generated discharge summary that sounded like somebody picked up a dictaphone, which I may have to explain to younger viewers of this. But the idea being that we could give a carrot, we could follow things better, and at the same time, be able to track things. And that was really my first involvement with APGO. Was Dr. Holzman and I took that concept to APGO as a poster. And from there on, I just became involved in APGO. It was a neat organization, lots of interesting things going on. And it was also around that same time that I started getting involved with the college through Prologue and eventually the CREOG in-service exam and so forth. So.
When you were developing those new things in Georgia, you were also developing something that we had never used in OBGYN, and that was a computer-based learning program.
Mm-hmm.
What led you to that type of development?
Just a nerd. And in fact, it was being a nerd that got me into OBGYN in the first place. When I finished medical school, I was undecided between general surgery and OBGYN. I enjoyed the surgical aspects of things, and it was about the last year that internship and residency were still separate. So I did a general surgery internship, figuring either direction I went, that would be good background and experience. And it came time to then apply for the residency, again, a separate process. So I applied to both residencies at Northwestern, hoping one of them would take me, and then I'd just go with whichever did. Again, not very good career planning, but I was happy with it. And I happened to be talking to the chair of OBGYN and asked him sort of what kind of bribes were they offering. And he happened to say that he knew that I was a nerd, and if I came to OBGYN, they would send me to Oklahoma City to study under Ross Brown, who was one of the pioneers of ultrasonography. I said, fine, sold. So I ended up going into OBGYN. Now, in retrospect, it was the right decision for the wrong reasons, because I really enjoy the continuity of care that OBGYN has, the ability to follow patients over a longer time and that. So while I'm sure I could have been a general surgeon, I am glad that I ended up in our field and that we have had an opportunity to see the depth and breadth that is part of what we do. But it was being a nerd that got me there, and so the idea of applying computers, which were at that time, certainly the desktop type of computer, was still a very new device. My first computer was an Apple II Plus with 48K of memory. Watches contain thousands of times more than that now, so it was just an opportunity to do something new.
What led you to develop actual programs, though, as opposed to what most people at that time were doing, was just putting them up with maybe a slide or something on it or a face on it, and yet your programs were interactive. Mm-hmm. I still remember those early programs.
Yeah, well, I think it's like a lot of things, I just didn't know any better. It was a matter that it seemed logical we ought to be able to do it. and I didn't know enough about it to know that I shouldn't be able to do it. And so we just tried it. That's happened a lot of things. When I was in practice, I'd mentioned that I'd been nominated for some awards. I ended up doing a lot of work on dysmenorrhea with the early work in non-steroidal anti-inflammatory drugs. Park Davis was investigating Ponstol at the time, and one of my colleagues had done some other work for Park Davis, and so he asked if I'd be interested in being a part of that. It turned out that the person who was overseeing that project was a retired OBGYN. And we happened to meet, and he said, well, this is a terrible project because we're trying to measure pain. We're trying to measure pain that happened a month ago. What would really be neat is if we could measure what the uterus was doing. Again, I was too dumb to know that it had been done before the invention of the sphygmomanometer. So I went about figuring out a way to do it with a micro-tip transducer that was actually being used at the time for cardiac work. And we ended up doing objective measurements of uterine activity and demonstrating that the non-steroidal drugs were actually inhibiting the process rather than providing pain relief. So I think, so many times in my life it's been a matter that I just didn't know any better and went ahead and tried.
Well, there's nothing wrong when you succeed.
Well, yes. On the other hand, there's no guarantee that you will.
Those early programs that you and Jerry developed there in the program, I remember at some of the APGO meetings when they would be demonstrated, you'd just be hundreds of people trying to get around to see what it was doing. They were so popular.
Well, it was an idea whose time had come. The idea of making something interactive, of using the tool in an effective way. So often in education, we have seen the process as being the outcome rather than looking at the real outcome. That's part of what was behind the ACGME's move from tell me how you teach something to show me that you did teach it. Same idea here was just using a computer isn't enough to create useful process or to do it any better. We have all seen that with our checkbooks. The reality is you really don't need a computer to keep track of your checkbook. But if we could do it in some way that would actually take advantage of what computers can do, then there'd be extra value. The same thing was true for educational things. If all I did was create a copy of a textbook on a computer screen, I've just migrated the information. But if instead I convey that information in some other way, interactively, engagingly, something that can address the specific needs of a given learner, then using a computer makes sense. And it was that sort of, again, not necessarily conscious, but unconscious desire to move in that direction that I think was what was behind most of it.
And where do you see the future of that going?
Well, that's always a difficult question to answer, which is, I suspect, why you asked it. Clearly, I think the technologies are going to give us amazing tools, whether it's virtual reality or neural networks that can learn and help us with things like diagnosis or management decisions and things. Those technologies are going to be there and they will give us good tools. It will be up to us to use them in new and innovative ways. So just because I can do something doesn't mean it's the best way to do it. That's been true of flipped classrooms. There are some situations where that's a great tool, others where it isn't. Simulation is great, but it can't teach some things. We have to pick and choose how we're going to use that technology. And until we really can get into it, I'm not sure we're going to know the answer to that question. The hope is that we will have talented people who will look at it and do so with an open mind and say, let's not do it the same way twice, let's figure out another way to do it.
You still use the computer for examinations. We use it to do things that some of us question as to whether what we're doing is just getting regurgitation or whether we're really measuring learning. How do you feel the computer could be used to really see that people are learning in our specialty?
A lot of that would be predicated on how do we know what learning is and how would we detect it. Certainly it meets the pornography test. I know it when I see it. But on the other hand, would a computer ever be better than, say, an oral examination? That's the difference between a written and an oral examination. Is in an oral examination where it is very interactive, you take someone who has content knowledge and can watch the process, watch the reasoning, tell me why, what would happen if. That kind of process, I think, is better at getting to knowledge that's usable. Because we've all known people who can do great on a one right answer test, but can't apply the information. Can I look at ways that someone has assimilated a principle and can apply it in a novel place? Now, given the changes that are happening with neural net learning and Bayesian things and fuzzy logic and all the other buzzwords in that sort of stuff, it's very possible that somewhere down the line we will have an interactive process that will allow you to sit at a terminal and do a competent oral type evaluation or some other version of that that could get to it. But not for a while yet.
Do you think we've reached the point in OBGYN where distant learning is going to ultimately replace the standard medical curriculum?
I think it certainly can augment it. There's no question that a lot of material in the classic didactic form can be supplied at a distance. You can join a web seminar and watch somebody being, presenting and so forth. However, in the current version of technology, there is some barrier to learning that occurs with that, and that we all know that watching a computer screen or a television screen with a talking head is nowhere near as compelling as someone standing on a stage telling their story. Someone with passion in front of an audience, whether it's a lecture hall or a meeting, who can convey that information, and you see more than just the narrow frame shot. Will the technology somehow get around that? I don't know. But at least at the moment, distance learning can provide on-demand, where needed kinds of learning that certainly is a great benefit. But will it replace other forms of learning? I'm sort of skeptical.
Let's just go back then. Under the standard medical curriculum, which I understand and you understand has been changing dramatically since when we went to medical school, do you think that we are improving the curriculum, or do you think what we're doing is just mixing and matching?
Depends on whether you're an optimist or a pessimist. If you're a pessimist, we're just rearranging deck chairs and we still are taking on water. If you're an optimist, then this is an opportunity to innovate, to try something new, an opportunity to fail. And if we don't have that opportunity, we won't find places where we can do something better and so forth. I tend to come down on the more positive side. I think that it gives us a chance to adapt to new learning styles by our younger learners who are used to technology, who think in shorter sound bites than we do and so forth. So I think that the innovations are well-intentioned, well thought out, and in many cases are proving to be very successful. But we have to be careful that we don't innovate just to innovate, and that we don't throw out good things just because something else is new. It's a little like the question of the role for, say, robotics. Interesting, glitzy. Have we proven it? Is it a tool that has a major role or a minor role or somewhere in between? Same thing goes for the educational processes, with classrooms, distance learning, things like that. We need to innovate, we need to try them, we need to develop the strengths of each of those, but we shouldn't just blindly say this is going to be it in all situations, in all cases. Same thing's true for any therapeutics that we do. All of these things have parallels in different domains.
I remember those early days in APGO when we were developing tape slideshows.
Yes.
That was the
35 millimeter.
Yep. Now, I don't think you could find one if you wanted to.
I think I still have some on my shelf, but they are the old versions.
The old version. What would you do if you could change medical education today?
That's a difficult question because it makes assumptions that, A, that I've got any sort of expertise, B, that there are problems with the education, and C, that improvements are out there that we just haven't been smart enough to see or whatever.
Well, I will disagree with number one, that you don't know anything about education.
But I'm not sure that I can foresee the future enough to say this is what we should have been doing or what we will do. I think what I would like to see are educational processes that have been sufficiently vetted. The idea of evidence-based education. We do evidence-based medicine. We have not done a good job of doing evidence-based education. We've not done a very good job across all domains in medicine in studying educational things. The idea of taking 5 lap pads, putting some red water on them, and asking 4 residents if they like doing the process is not education research. And unless we do research on how we are teaching and what is working, we won't know the best tools and we won't be able to use them. So in terms of things that I would like to see happen, or that would be nice if we had been doing, it would be nice if we'd been doing that for a while. I would like to see efficient teaching methods that convey information in useful ways, in chunks that are manageable and can be assimilated, because there's so much that has to be learned. We've got talented young folks as students and as residents. We shouldn't waste their time. We need to make sure that we can give them the best start we can before they're turned loose. And then once they're out of our educational domain, med schools or residency, we need to ensure that that education continues with things like the college does, with prologue and interactive programs and the annual meetings and so forth, to ensure that we are continuing that arc of education and knowledge growth that is so vital to being a good physician.
Right now, there's still a lot of discussion about the 4th year of medical school.
Mm-hmm. Yeah.
As I recall, we were having that discussion many years ago.
Has not changed.
And we've had 2 or 3 big meetings on it.
Oh yeah, and the same argument has been happening about the 4th year of residency. You know, is there a place for that 4th year being more specialized, being more focused, especially as we're having more and more of our graduates going out and pursuing fellowship and advanced training? Should we try and shorten that time? Should we try and make it more efficient? All ideas that ought to be explored. Many of them have logistical problems or other barriers, but that doesn't mean we shouldn't be looking at them. Same thing for the med school. Yes, in the traditional curriculum, the 4th year, especially the last half of the 4th year, often is very much inefficient, let's say. I won't say wasted, but inefficient. Maybe that's just a matter that we haven't figured out that there is so much more information that we need to convey that we need to get more effective and more efficient and pack things into that year. Whether it is better focus on final career path, or in helping make sure that the person who goes into a different specialty, different from ours, or in ours different from another specialty, gets the best depth and breadth across the entire spectrum. As OBGYNs, we don't do a good job if we don't understand internal medicine and family medicine and nephrology and imaging technology. Similarly, I have done a disservice to the cardiologist who leaves my medical school if he doesn't understand women's health care and the differences that his female patients will have in their physiology or their needs or whatever it may be. Maybe we could take better use of that in the 4th year, but it's going to take consistent things. We are already seeing some changes, but we're not there yet. Doesn't mean we won't get there.
What do you think about this new concept we have in resident education now called Milestones?
We've always had milestones. The trick was we didn't articulate them well. We always knew when somebody had good hands. We always knew when somebody was getting it, when somebody was falling behind, and so forth. The idea of milestones, I think, is excellent because it gives us definable standards. They're measurable. Both the learner and the evaluator knows where the endpoints are, what the goals are. So I think that they are good, and they also are accountable to our ultimate consumer, to the patients that we care for, and so on. That we can say these are the things that a graduate of an OBGYN residency, or if you were to extend it backwards into med schools, graduate of an allopathic or osteopathic medical school have accomplished. This is what we're expecting to turn out. So I think milestones are a good process. It's been angst to get them there, and there probably will continue to be refinements, but we've always had them. We just didn't have a list.
Do you think now that we've moved to milestones in a formal process that we reach the point where a standard curriculum is not, or standard residency is not 4 years or 3 years or whatever, but it is a point on the milestone grid that once you reach that, then you're finished.
And you're done. That certainly is a concept that makes sense and has been adopted in some places, not in the U.S., but around the world. And I think that it may have some merit. If you can achieve the experience, the knowledge in that, do we add any value by adding time? Conversely, just because you put in the time does not mean that you are automatically qualified or should be awarded the degree, the certificate, or whatever it is. We see this in faculty. Yeah, you put in 7 years, but that doesn't make you a professor. Same idea may be that you put in 4 years as a resident, but you're still not quite there and you need another 3 months. But if we do that, we need to be very focused on how we're going to make sure that the learner gets to that point, that we constantly are identifying them early in the process, because this takes a lot of time and effort and capital, emotional, physical, monetary, to train somebody. We do them a disservice if we don't help them meet the 4 years, or for that matter, even accelerate it, because they're losing earning potential by being held over another year, or whatever it may be. But I think it is, like so many things, an idea that we shouldn't reject without serious consideration.
We've been involved back and forth with lots of educational projects over the years. Which ones were you the most happy you were in, and which ones were you the most, let's just say at the end,
which of your children do you like the best?
Yeah. Which do you like the best, or which would you wish you didn't have?
I have always considered it a profound privilege to be a part of the work of the college. I've had a chance to sit at the table for prologue, for Précis when it was being done, for the APGO training examination. Each of those have been just incredibly rewarding. To be able to sit at the table with the people that I've read their articles, I've read their textbooks. How on earth did I get to sit with the grown-ups? I still consider that a privilege, and so each of those projects has been both a privilege and a distinct pleasure, but often in slightly different ways. What could be more fun than trying to figure out how to ask a question that gets to your idea of has learning occurred or something? What could be more fun than trying to figure out what's relevant and has changed and how to write that in a Précis? How to get somebody to think about a concept through the question in prologue and then the discussion that happens after it. Each of those brings great rewards and different sort of feel, and I wouldn't trade any of them. I wouldn't have given up any of them, and each of them has just been a delight to be a part of.
What's your biggest regrets?
That's a little like asking what's your greatest accomplishment.
No.
Because one time I was asked that on a job interview, and I said potty training, because if you don't do that, really nothing else after that matters. I didn't get a call back for the second interview on that, so I'm not sure that greatest regret's going to have any more grounded answer than that. I would love to have had more of an impact. I'd love to be able to say that that we've had a place at the table and so on. But I've had those things. I mean, I've just been extraordinarily fortunate to be in the right place at the right time through often no merit at all. And so if there is regret, it is that I may have let down a mentor, or I may have not done everything that could have been done. But I don't know that I can identify a specific thing.
Roger, I cannot think of a single thing that you would. I have watched your career, well, because we're pretty much contemporaries.
Yes, sir.
And we've been together in a lot of different ways, and I've always respected your educational ability. And I think you have, coming from a practice like you did, you've brought, at least from my point of view, you have brought a different perspective to education.
That was what made me decide to go into it. So I hope that's been accomplished.
You have accomplished it, I know. I know from the point of view of ACOG you have. I haven't been in either of your universities, but I'm sure they're very happy with you.
Sounds good.
I want to really thank you for coming and sharing this with you, because you are one of the premier educators in our specialty. And it's been very nice to sit and just chat with you here and not having to chat with you about a problem about how are we going to teach something or other.
It's been a distinct honor and privilege, sir.
Thank you very much, Roger.
you.